Partnering with Families, Training 2, Identifying and Overcoming Barriers. Today we're going to talk about barriers. So your presenters for today, oops, I'm so sorry, is Lydia Franco. If you'd like to introduce yourself.
Thanks, Maria. So good afternoon, everybody. My name is Lydia Franco. I am a social worker and I work at the NYU McSilver Institute as the Education Innovation Officer supporting statewide training. My background as a social worker has been primarily working with children and families and with a focus on strengthening families and engagement and partnership with families as well as peer support. So I'm excited to be here today to talk about barriers and partnership. And I'll pass it back to Maria to introduce herself.
Thank you, Lydia. So my name is Maria Fuentes. I am a credential family peer advocate, and I work at McSilver supporting the technical assistance centers. And I'm helping by supporting and enhancing the family voice into all the work that we do. Um, so I have worked with families as a family peer advocate for many, many years, and I have lived experience as well, which is why I'm a family peer advocate. Um, Okay, so some housekeeping items. We are gonna, well, everybody that comes in is muted. We're gonna ask you to please use the chat for anything that you may want to tell us or to interact with us. Um, a live closed captioning is available. You should be able to see it on the bottom of the screen. If you have any technical difficulties or anything comes up, you can chat in with admin, with Angelique or Felicia, who is helping us today. Also, the webinar slides will be available in our new URL, mcsilverta.org, and we will share that information with you as it comes available.
Yeah, can
Okay.
I just add one more housekeeping piece there?
Yes, ma'am.
This, as you know, this is a three-part series. The full three parts has CEs available. I just encourage everybody to make sure that you're logged in under your name so you can get credit for attendance if you're interested in getting CEs at the end of the three-part series. So I just want to highlight that, and that you have to make sure that you're logged in through the Zoom app and not just like a phone call, either on your computer, but just make sure you're in the Zoom with your name, and it tied to your appropriate email. Thank you.
Thank you, Lydia. So next we're gonna ask you to introduce yourselves in the chat. I know some people already started doing that. Thank you so much. We want to know who's here, right? Are you what is your role in the agency that you are working with? We'll definitely check that out.
Yeah, and just let us know if you are what level, or are you a clinician, or you're a peer supervisor. We love to see who's here, and also where you're coming from. We have quite a few folks on, so appreciate everybody coming on, especially on a Friday.
Yes, thank you for joining us on Friday. So as it was mentioned before, this is a three-part series. Training 1, which was actually on Monday, it was about families and caregivers as partners. Um, and, there was some information about why partnering with families was important, the framework, meeting with families where they're at. You guys met Randall, the ones that were here, and Mom, and then you were followed with some next steps. Today is training 2, identifying overcoming barriers. And we will talk a little bit about what we're going to do today. And then you have a training 3 on Monday, so don't miss it. Engagement is partnering. There'll be a lot of strategies and some super good information to follow the work that we're doing today. Okay. So we asked on a Monday, a reflection from the first training, right? We asked for those that were here to think about two caregivers that you can identify. Um, and the training should be in mcsilverta.org in case you missed that training. It was phenomenal. So this training, since it was focused about the importance of partnership with families and highlighting of family-driven care, um, if you can identify two families that you were working with, right, or caregivers that you have worked with, and consider throughout this training the barriers that they may have encountered or they may have been going through at the time that they were working with you, and how that play a role when you were trying to engage them, when you were trying to build that relationship with them, and what did that look like. So we would like you to keep that in mind if there were any barriers, right? But we'll talk about that today. All right, so now let's talk about barriers. This is our agenda for today. We're going to talk about barriers. What are barriers to engagement? How do we identify barriers? We will share a family story in a vignette. So we're going to have a breakout room. It's going to be super fun. And then we will end with some next steps for you guys to be ready for the next training on Monday. So let's get started. All right, super exciting. So the definition of barriers, this is a general definition of barriers in mental health treatment, right? And what are barriers? Any factors that prevent a child and family from accessing and receiving necessary mental health care. With this general understanding now, let's talk about barriers, which are specific to engaging or partnering with families. So if you use your chat, can you tell us what are some barriers families experience when seeking services? What are things that can get in the way to be able to build those relationships? Or, what can get in the way of those families obtaining those services that they need and they deserve?
Language barriers.
What was that? I'm sorry.
Language barriers.
Yeah, thank you for that.
Transportation issues.
Yes. I see complicated systems in place.
Scheduling.
Scheduling, yes.
So we see a
Fears.
lot of coming in, right? So we also see stigma, lack of resources, stereotypes, transportation, bad history with similar services. It keeps coming. Thank you, ICE.
Thank you. Yeah,
Immigration challenges. Thank you for acknowledging that. Schedules, fears about being deported if they seek help, literacy, financial instability. There's quite a few here, Maria.
absolutely. Thank you so much. Yes, you guys came ready to this training. And we're gonna talk a little bit more and mince it a little bit more for all of you. So thank you so much for sharing. Now we're gonna talk a little bit more about other types of barriers, some of that were not mentioned, and we're gonna discuss this further. Pass it to Lydia.
Thanks so much, Maria. So feel free to keep chatting and sort of highlighting some of the things that you're seeing. Actually, you guys covered a variety of different barriers, and I think some of those are going to be subsumed in some of the things that we're talking about. So I'm glad to see that you all are very much in line with some of the things we're going to cover. I also appreciate that there's a number of folks who are clinicians here, but I also saw a lot of supervisors. So thank you also for taking the time to join and participate in this conversation. I really appreciate that we have folks from a variety of levels on because from our perspective, barriers actually are sort of multi dimensional and come from a variety of different kind of spaces, and having folks at different levels is incredibly important and powerful to attend to sort of barriers. And so I want to sort of highlight that our focus is really partnering with families. today's presentation is really about the things that get in the way of building that partnership and that connection and that engagement. I think one of the things we want to sort of ground is when we're talking about partnership, from like a clinical lens, for example, we oftentimes talk about like building a therapeutic relationship or a therapeutic bond, right? We also focus, and I think you heard a lot about this in training one, around sort of focus on family-driven care, and building a sort of connections with families and collaboration in service of in supporting both the child and the family as a whole. So we really are coming from that lens. So one of the things that we want to highlight are what are the things that get in the way of connecting with caregivers or connecting with the family, that can prevent us from partnership. And some of these, some of these may be new. We may also be asking you to think about them a little differently than you have in the past. And we're going to kind of check in with you all to see how you connect with the content as the presentation kind of goes on. So we will first go into practical, concrete strategies. Then we're going to talk about perceptual, attitudinal, family ecology, and systemic. One thing I want to point out, and Maria and I spent a lot of time talking about these barriers, is that they're not so cleanly divided. I think we decided to sort of focus on these four main categories because it's easier kind of to digest and try to understand. But many of them really intersect and they're not such sort of clean boundaries. This is really just a way for us to be able to hit sort of the core categories that we want to make sure we would communicated, but there also may be many barriers that we don't get a chance to touch on today. So just keep that in mind. All right, there we go. So practical concrete barriers. Now these are the ones that some of you mentioned, like transportation, difficulty to get time off of work. So like you can't, the schedule of the clinic doesn't match with your work schedule. It's hard to get there. You may have other children and you need childcare. You have to sort of split coming to sessions because you have sort of children with different priorities or different needs at the same time. You may be providing elder care and taking care of your own parents. You may have other sort of issues that are kind of getting in the way. You may not have easily accessible transportation for you. The way I view sort of these practical concrete barriers is that they're focused on the individual. So this isn't systemic per se. We will touch on systemic later, but in my mind, this is more specific to like the unique needs or the unique challenges that individual family may be dealing with. So like what, their own competing priorities, for example, and things like that. So one of the things we want to highlight about practical or concrete barriers are like, these are the ones that are more matter of fact. They're the ones that oftentimes we hear the most. So if we have families that are missing sessions and we say, hey, notice that you missed the last couple sessions or you haven't been able to come consistently, can you tell me why that is? These are oftentimes the reasons we'll hear, right? We'll hear that, oh, I'm sorry, I couldn't make it or whatever. And these are very real barriers. And oftentimes these barriers are sort of probably easier ones to problem solve because they're very concrete, right? They're very kind of matter of fact issues and you can kind of problem solve them. I will say that there's another set of barriers called perceptual or attitudinal barriers, which many of you did allude to in some of the things that you were saying. That is a little different. These are the barriers that I would argue, and I think the research on engagement and family involvement also highlights is the most sort of important barriers to attend to, but they're not the ones you hear about. And they don't necessarily, they're not necessarily stated as directly as more concrete barriers. So for example, perceptual attitudinal barriers, or just to kind of define, they're related to perceptions, attitudes, or beliefs that come from the perspective of either the family or the provider. So oftentimes you hear about these things like sort of what is the family bringing to the table? What are their sort of perceptions or attitudes that are contributing to engagement or connection with services? When we think about building a therapeutic relationship and a partnership, I think it's important for us to understand that we each bring something to the table, right? So the child brings something to the table and their own perceptions. The caregiver brings something to the table. but we're just as much a part of that relationship as anybody else. And we also, as providers, bring our own perceptions and attitudes to the table. So one of the things we wanted to spend a little time talking about are these perceptual attitudinal barriers that each of one of us, each of the stakeholders in this partnership may bring. We also do know, as I think I maybe mentioned, is that the literature on engagement highlights that not all barriers are created equal, and that perceptual barriers are actually some of the most important ones that we need to spend some time on, but they're not the easiest ones to talk about. And because they're not the easiest ones to talk about, they oftentimes go unsaid, and we may not be aware that they exist. So we did want to spend a little bit of time here and process this a little bit and talk through. And we're going to check in with you all to like give us some thoughts around how you've seen some of these things at play in the work that you've been doing as well. We wanted to start off talking a little bit about sort of what providers bring to the table, but I also wanted to be mindful that the perceptions and our attitudes, everything we bring and each of the stakeholders brings to this partnership and this relationship oftentimes comes from the context in which we function in, right? So providers, for example, have a context in which we function in, right? The demands of the job can be extremely frustrating, can be overwhelming, can be taxing, right? There's a lot of time constraints, there's productivity demands. Oftentimes you have all these requirements you have to follow. So documentation upon documentation upon documentation and all the time spent there, right? Focus on agency protocol requirements. We may be in settings where maybe we don't have access to professional development, or we may have minimal supervision support. So we may be in a space where we may not feel as supported or as comfortable, and also may be strained, and the expectations are very demanding on us. At the same time, the last bullet is not quite the work context per se, but it does contribute to what we bring to the table, is that we also have our own personal values and beliefs, our own experiences. On top of that, the sort of work context that we are bringing to the table every time we meet families on a day-to-day basis. So all that comes with us, oftentimes whether we see it or not, right? And more often than not, we may not see that we're bringing all this with us every time we're meeting with families. So the demands of this job can be very frustrating and taxing, right? So oftentimes when you're working with caregivers and families, and we oftentimes hear this, we do a lot of work, Maria and I work with a lot of different programs, and we're talking about family engagement, and we oftentimes hear providers kind of espousing some of the challenges that they have in engaging and partnering with families and involving them in services. And what we hear sometimes is that providers may feel sort of reluctant or anxious in engaging the caregiver. They may be unsure about how to do it, or they may be ambivalent, like they may not want to, or may not, like they're kind of on the fence. They may be avoidant. We've also had, and I've also seen folks that kind of like go out of their way a little bit, and maybe it's tied to fear or needing sort of additional supports that they may kind of not, and I don't think any of this is intentional. I think sometimes we may sort of avoid even engaging with the caregiver. Sometimes we're not sure what the reaction we're going to get from the caregiver, or what we're going to, what folks are going to say to us. So we may be a little fearful, especially if you're more on like the inexperienced side, or if you hadn't had enough experience working with families as a whole. And I think underlying all of this is this concept of compassion fatigue, which I think many of us are familiar with, and I'm sure you've had in a lot of trainings. But I do want to highlight the importance of this and how this plays a role in what providers kind of bring to the table in these partnerships, in this relationship. So compassion fatigue, and it's been written about in a few different ways, or different sort of lines of research in this. But compassion fatigue, I love this quote, it affects those who do their work well, right? You're putting your all into this work, and you're getting potentially a bit exhausted. It may ebb and flow. It isn't like a constant exhaustion, but oftentimes we see this when there's a lot of like overload of work, or too many sort of demands, and you start feeling a shift in the hope and the optimism, the value of the work, and you start struggling a little bit with how sort of you're viewing sort of the balance that you have with the workload. So it starts to feel a little a little bit much, right? What happens with compassion fatigue though is that you may have good days and bad days, right? So good days where you feel like, oh, it's all too much, and then the next day it could be a lot better. So you're still kind of like in and out of this experience. You're not solely tired or permanently fatigued. Burnout, however, if you continue down that path and you end up with burnout, which I think many of us are very familiar with, and is so commonplace in our profession and just the general helping professions. Whenever you work with people, this is extremely commonplace. Burnout is where you really see this, right, in environments where there's high workloads and non-supportive work environments, right? And you shift in the way you view your work and how you view yourself in doing the work, right? So you start really feeling hopeless. You're very exhausted, especially emotionally exhausted. You kind of start feeling like you don't like you're not making a difference anymore, and you start feeling like you're not as you don't feel as confident in the work anymore. And this also leads to feelings of depersonalization, which then results in cynical attitudes towards clients. So what ends up happening oftentimes, and I think we've all known folks who where this kind of happens. I think it's very commonplace actually, where you start seeing folks not you may not say the most positive things about the consumers that you're working with, right? There's a little bit more cynicism. It's harder to be strength based. It becomes harder to be empowering and supporting the consumers, the families that you're working with. It's most of the interactions feels a little bit sort of negative. And that happens with burnout. I think that's one of the main indicators I think oftentimes we see with burnout is that it's hard to do your work well when you're burnt out. It is hard to use best practices and be strength-based and validating and pairing and all of that whole list of things that we're supposed to be doing and family driven when you're burnt out. Because the symptoms are in total opposition of those best practices, right? So I really love I read this at some point somewhere, which I really found this interesting. It's sort of like a quick little question you can ask yourself about burnout. So if you ask yourself, do you love your work? If your answer is yes, so let me take a step back. If you feel exhausted and you ask yourself if you love your work, if your answer is yes, I still love my work, but you're feeling a little exhausted, probably more like compassion fatigue. If you ask yourself that question and you're feeling exhausted and your answer is no, I actually don't love my work very much right now, chances are you're on the path to burnout. So at the end of the training, we're going to share some resources for folks to kind of also self-reflect on sort of where they are in this path. And it's really important to kind of check in. But as you can see, these are all potential barriers. These are all potential things that can get in the way of developing really positive and effective partnerships with the people we work with. Shifting a little bit to families, and I want to talk a little bit about history here. And actually, Maria would probably be the better person to do this, but I got this section. The family advocacy movement and the family movement had worked for a long time, for decades, really trying to shift the way across the country, like across the way the mental health system kind of viewed and worked with families. And about a decade ago, I would say, Maria, there was this sort of shift where family advocacy groups really got to the point where they were able to sort of develop this concept of family-driven care, right? And the work that was done to sort of infuse the concept of family-driven care in systems, right? And it's taken a long time, and I think we're still working on that. But you now see the concepts of family-driven care more embedded in the system than it had been before. But the reason why that movement happened, and a lot of this comes from sort of NAMI and some of the other sort of family advocacy groups out there as well, is that families at the time caregivers were feeling that from the mental health system, they were viewed as obstacles, for example, like that the caregiver was just in the way of the child getting treatment, or that we had pity of the caregiver, right? Or that we viewed the caregiver as having deficits or needing re-education or reparenting. Or we viewed the caregiver is not interested or invested in their child. And so a lot of families really struggled with this and navigating the system when they felt that they perceived that this is how they were being viewed from the providers and the different groups in the mental health system that they were struggling with, which led to this major movement across the country. So that feeling, those experiences that they had led families to feel like they were prejudged, that they weren't heard, that they weren't respected, that they were blamed or shamed, that they were misunderstood, that the decisions were made without them. There wasn't shared decision making, that things were kind of pre-made and you just had to follow them. And so what we found is that a lot of these families were really struggling with this and sort of feeling like the sort of the negative aspects of working, like connecting and having to navigate the mental health system. And what we know is the studies have shown that caregivers often feel unsupported when providers, unsupported even when providers thought they were being supportive. So let me give you an example. There was a lot of studies done around engagement. I love this work. So I think it's really fascinating. But there was a lot of studies done in a certain period of time where what the researchers did was that they followed like pairs of providers and caregivers or providers and families. And what they would do is that they would interview them right after they had a session. So the provider and that caregiver had a session. They would each get interviewed separately around their perspective on the session. And so more often than not, these studies found that the provider and the caregiver viewed that session totally differently. Not all the time, but a lot of the time, and in this kind of surprising way, they viewed them differently. And oftentimes what they found is that the providers rated the session higher than the caregiver had. So what's happening there? There's a disconnect or some sort of mismatch in the experience, that the provider's feeling that that session went one way, the caregiver is feeling that the session went another way. And so these are just some quick quotes, similar to some of the things we were just talking about in the other slides. I won't read the quotes, but this was some of the quotes from the interviews, for example, that they had with the caregivers, right? And some of the frustration that those caregivers had in the interactions and when they were getting services for their children, right? And basically it's the same kind of messaging, right? They didn't feel like they were truly included, that their needs were being met, or that they were heard. So oftentimes what we see, right, and is that caregivers who then feel blamed or they feel shamed or all these sort of negative experiences, you begin to have then low expectations for treatment. So if I'm seeing somebody and I don't feel like they're truly understanding me, I'm less likely to think that that treatment's going to go well or that there will be positive outcomes. So what happens? I'm less likely to engage. I'm less likely to participate or connect because I don't feel it's going to work, right? And so sometimes what you'll see is families or caregivers, maybe pulling back, right? Or maybe they never truly connect. It kind of depends on where you are in this process. And oftentimes what we find is that providers call this words that I do not love. I got to be honest about that. But word like resistant. So we hear the word resistant. The parent is resistant all the time, or they're non-compliant. And so, but now you sort of understand, right? I'm less likely to engage or participate, which is viewed as resistant, but is actually a response to how I feel that the services aren't aligning with what I feel we need, right? And so that's the disconnect. So now there's this disconnect. Everybody's sort of bringing something different to the table, and the partnership is not clicking. That relationship is not working. And this is important to sort of understand that there's these processes that play and a lot of sort of relational interaction that we have to be mindful from all the different stakeholders in the partnership. In line with this is prior experiences with services, right? So if I, as a parent, and chances are by the time they get to us, like they may have received services from a variety of different places or have had different experiences with different systems, let's say schools, for example, or child welfare. Um, Sometimes those experiences aren't so great. So oftentimes they've been oriented to services in a negative way, and you bring that with you to the next service. And so you may perceive the current service as also potentially being negative because that was your experience in the past. I'm going to take a second to drink some water, but I'm going to open up the chat. I'm going to ask you if you haven't, I just realized there's a little typo here. How have you seen caregivers' past experiences with providers impact your ability to partner with them? Like, how have you seen, if you have, how those past experiences then sort of bled into the work that you were doing? And I'd love to also hear a little bit about what you did about that. So if you can take a minute, chat, Maria, if you can help me with the chat while I take a sip of water, I'd appreciate
Sure.
that.
No problem. So feel free to unmute and share with us or use the chat. So how have you seen caregivers' past experiences with providers impact your ability to partner with them? The family caregiver has not been trustful, reserved with their responses, not telling full story or situation details. Caregiver has stated that agency or service had not been helpful in the past, so there's belief it's not going to work this time either. Yeah, that's definitely guarded due to constant turnover, lack of trust and engagement, resistant to discuss certain things. They don't believe that they can get help because they weren't able in the past. Yeah. Fear of being penalized. Yeah, that punitive approach sometimes. And sometimes as Lydia was mentioning, right, this comes from burnout too. So when we're wearing that provider hat, there's so many things that are on our plate that can also contribute to that. So how are we showing that to the families, right? Or how is that impeding our relationship with them? Lack of reliability of previous providers, caregivers withheld crucial info on clients due to fear of agency call, buying hospitalization. Yeah. Fear of other systems, of other agencies getting involved. Families with long history of involvement with outside services, reluctant to work with new services due to receiving no help. Yeah, very
Yeah.
unfortunate.
Yeah. I mean, I think you all hit the nail on the head, and I think this is also very common. It just shows how commonplace it is, right? So if we know coming in that it's very commonplace, like for folks to bring in these past experiences, how can then we think about the work we're doing differently so we're tapping into those and talking through those earlier on? And some of that will also get covered in part 3 of our training, where we're going to talk a bit more about strategies for partnership. But thank you so much for sharing that. We wanted to spend just a little bit of time talking about mental health stigma, because that's sort of the flip side of some of this. And stigma can come from all different directions. As we know, mental health stigma is a set of stereotypical beliefs, prejudicial attitudes, and discriminatory behavior against people with mental health conditions. You were so great at sort of chatting in just now some of the things that you've seen. Can you chat in what does mental health stigma look like from your experience? Like, how have you seen mental health stigma play a role with the families you're working with, even with yourself, and maybe experiences that you've had, both professionally and maybe personally, if you want to. But how do you see mental health stigma popping up in the work that you're doing? And Maria, if you can help me with the chat again, that'd be great too.
Yes. People don't want to go to receive services, receive a label, or engage in treatment. They don't want anyone to know. Unwilling to access services or delay in access. Often the diagnosis becomes the identity. Yeah, that labeling is a lot. Unwilling to get services due to be labeled. That's huge. And that is very common. Think it would just go away without talking to someone to avoid the labels, stigma. Families don't believe in mental health. They don't want their child label, culture. Students feel very embarrassed when they are
Mhm.
receiving counseling or case management for fear that other students or teachers will look at them differently.
Mhm.
Yes, especially when we're working with young adults, right? I've heard horror stories from other people who had negative experiences. System avoidance, fear of deportation, which is very real. Youth feels that family sees them as broken, unwilling to be forthcoming
Yeah.
about their mental health due to negative viewpoints. Fear of appearing weak or less than.
Mhm. Thank you, everybody. I mean, I think you really hit a lot of the different types of mental health stigma too, and we're going to briefly just highlight these because I even wasn't aware of sort of all the different variations, right, in which this exists. I wanted to highlight that, and then you can sort of think through how do some of these play a role in the work that you're doing with the families that you're working with. But it can be sort of layered, and stigma can come from a variety of different directions. So I think the one that we know most is public mental health stigma. So the idea of like what is societal stereotypes, like what's said in larger society that the general population kind of has an understanding of around people with mental health conditions, right? Oftentimes it's very stereotypical, a lot of negative attitudes, the media and how the media sort of shows people with mental health conditions. So you'll see that sort of stigma perpetuated, and that messaging comes to all of us, right? No matter where we are. So that plays a significant role. And then there's self stigma. That's where I, as somebody with a mental health condition, am now internalizing those messages against myself, right? So I now sort of see myself as somebody who has a mental health condition in those negative ways, right? And so that plays a significant role and may be at play, which I think some of you said in that chat, with the families you're working with, or like, for example, you said that the youth was concerned about how the family was viewing them as well. So a lot of that has to do with sort of their own self stigma. It also can be connected to courtesy or associative mental health stigma. And that the way I see that is more about people in proximity to other people with mental health conditions. So the parents, the cousins, the friends of somebody with mental health conditions, and that those people also get stigma. We had a longtime friend who's a family peer advocate who had talked about when her child started receiving services and sort of became more known as somebody who had some challenges, that she received a lot of community based stigma with herself and her family. So by the proximity to the person with the mental health condition, they also were stigmatized, right? Then there's institutional stigma, right? So that's where organizations, like institutions, have policies, procedures, things like that, that also perpetuate stigma. And that's like another space for us to think about is like there's so many places in which we may be getting messages of stigma and or where we may be perpetuating stigma. And it's really interesting to think about when you stop to sort of look at it this way. Intersectional stigma has a lot to do with intersectionality, right? The idea being is that if you're experiencing stigma from having a mental health condition, but there's also stigma and discrimination and stereotypes from, let's say, if you're with another sort of marginalized group. So let's say LGBTQI populations, right? So there's two layers there of stigma, or more, depending on sort of what how it all plays out for you. And then professional and provider stigma, which is one that I hadn't really heard about either, which was really interesting to learn about. And there's like two sides to this. One is similar to that proximity piece, is that we as providers who work in the mental health system and support people with mental health conditions, we may also get stigma, right? So, and negative views about the work that we're doing, right? And so I sometimes think about that as like when you share with people like where you work or what you do, like you may get a, like a face or something like that, like why are you doing that, or you know, so that there's messaging and negative messaging that we may be getting as professionals who work in this space. On the flip side of that, similar to institutional stigma, providers can also kind of fall prey to the same sort of biases, right? Because we all get the same messaging and we may unintentionally perpetuate stigma too. So it's really fascinating to see sort of how stigma really plays a role. But I do believe, and many of you said this in that chat, that stigma plays a significant role in how we connect with the people we're working with, how we build those partnerships, how they view us, and how they view themselves. That self stigma is pretty serious, and something we may want to think about. Like, how can I attend to that? How can we talk about stigma more openly? Um, I think I'm going to skip this chat to just kind of move on to the next piece, Maria, because I know you have a big section to get to as well. And we just spent a lot of time, I think, talking about stigma in the chat. Many of you mentioned this too, and this alludes to sort of the mention that I had earlier around stigmatizing language. So one way that we may unintentionally perpetuate stigma is by using stigmatizing language. I will say that oftentimes this is also a very institutional thing. So I remember when I, came out of school many years ago and I started working in a clinic setting, it was so commonplace to hear many of these words used, right, with the people that we're working on, what we were working with. And being that, especially as a social worker, you're oftentimes kind of learning on the job sometimes. You become acculturated to the environment in which you're working in. So I came in, this is sort of language that I heard. I thought, okay, this is how you do the work. Like, this is how we talk about people. And some of these words went into documentation. Like right now, I'm like, oh my God, I can't believe some of these words went into documentation, right? It's documented that we're using stigmatizing language. And so it was actually my work with, I was very lucky that for most of my career, I've been working alongside of community advocates and family advocates like Maria and others who helped me really understand and see this from a totally different viewpoint and from their viewpoint. And that's where it kind of really stuck to me that the words have meaning. And I think many of you mentioned like labeling, like we're like people may feel unnecessarily labeled, that sometimes we institutionally also label people. And I think what also happens when we label people, like for example, quote unquote, resistant, is that we start seeing people through those labels. It's a lens that filters our view of them. And it isn't usually a positive lens. It kind of leans us to a more negative way. So I generally try to avoid this. And this is in line, I think everyone knows, like a person centered movement or family driven movement is to move away from words like these, right? And to kind of shift our thinking a little bit in everything that we do. And when providers or staff stigmatize mental illness, I think we all know this. People can feel alienated. They may want to shut down. They feel disempowered and may less likely to participate in services. So there's a lot of like great work that we do in the system, and a lot of time and effort that we as providers put in working with youth and families. So there is a lot of positive. But today we're really focused on some of those barriers, the things that get in the way. So I do want to acknowledge that there's still a lot of good in the work that we're doing. But there's also things that we need to kind of think about that is getting in the way of the services that we're providing, and ideally for us being as effective and supportive as possible. Maria, I'm going to pass it over to you.
Thank you, Lydia. All right, so we're gonna talk about barriers through a family ecology lens. So what does this look like? Well, it can look like caregiver depression, multiply stress, isolation, trauma, substance abuse, family and marital conflict, and that's a lot of stuff, right? But we can also add diverse caregiver values. If they're trying to, get help seeking traditions, to stick to their beliefs, to be able to use their own language, which is something that did come up in the chat, right? To be able to share with us what their life experience has been, what their relevance to their culture is when linked to services and whatever program that they're in. Whatever agencies they're involved with, what is the perception of who they're working with, the staff that is around them, and the families that they're around. That being said, we can for example say that some things that may become potential barriers related to family ecology can be Any history of mental health, illness, or substance use, or any of all of this combined, right? Any history of trauma in the family. Oh, sorry. I do apologize. I do apologize. I kind of went somewhere else there. I'm sorry. Any history of trauma in the family. Diverse cultural and religious views and their views of mental health and treatment, right? Which I would like to add that culture in itself is not necessarily a barrier, right? It does not always have to be a negative thing or punitive or seen as something bad. And we're going to talk a little bit more about that, as well as the social determinants of health, for example, poverty. Right. And we're going to mince this a little bit more. But I would like to note that it is extremely important for us as providers to intentionally build relationships with the families that we're partnering with. Um, why? Because then that's how we are able to gather some information and be able to consider what is a barrier or not when we're actually talking to people from a different point of view. And it's something that came up when Lydia was talking before. It's like when we're working with a family, sometimes we're seeing parents as permissive, right? And we label them that. And it's hard. Like when you see a family through that lens, and you think about the family ecology, like where is this coming from? Where did it become that? And how can we understand a little bit more or support the families exactly where they are at, and be able to provide the services to them as needed? And also, what are these barriers coming because are there a protective factor in their families' lives? Like, is this happening? Are these barriers created because they are protective factors? Like, the only way we can know more is if we're actually being intentional about creating those relationships with these families to be able to do this. Now that we have covered the potential barriers related to family ecology, we can dig a little bit deeper into this. And now I could go to this slide. So substance use disorder can create extensive as well as multidimensional challenges that can touch every aspect of a family's life, which can include emotional well-being, financial stability, educational attainment. This can be a struggle they face on their daily reality and is not limited to one area, which can make it even more challenging to deal with or find any support for. The family's own personal history with mental health or substance use can create sometimes significant and complex barriers, right, to services. This can lead to untreated conditions and mistrust of the systems that are supposed to or they're intended to be able to help them and their families, which can create bigger barriers, which we will talk about in a little bit. This may explain one of the root causes of resistance to engaging with providers, as you know, the families are struggling to accept that they need support, but there are so many things that come in between. Many families have a history of negative experiences, which makes them less likely to seek or accept services, emphasizing the wide range of impact this has on the families, right? And the key area we will cover are the barriers specific to trauma, such as when we are trying to find some understanding of the mental health system and speak about some barriers that are very specific to trauma. Families who have experienced trauma may view mental health providers as intrusive due to the expectation of having to share painful experiences and having to connect to their feelings when seeking help for themselves or their children. Imagine that, having to sit every time they have a new provider, having to tell their whole story all over again. As a person with lived experience, as a family peer advocate, I feel like that is a very, very big challenge, right? For me, when we're switching providers. Because is re-traumatizing. It can definitely feel like my boundaries are being crossed completely as a parent, and my child's boundaries are being crossed, right? Like, what is it that why do I need to say all of this? Even though I have the understanding that this would help me in the long run, but it is not less emotionally exhausting because there is a purpose for it, right? So in turn, families, caregivers may appear defensive or reluctant to engaging because they know they need the support, but it is a painful transition to be able to get the support that they need. Um, some families may not want to discuss their traumatic experiences, right? Um, this could be psychologically, emotionally taxing. They may be already be overwhelmed, and they may still be in the same um, going through the same challenges without being able to get out of it, right? Which is huge. Some parents may unintentionally underestimate the effects of those traumatic experiences on their children or even for the whole family. And this could be because they are protecting themselves or they're using it as a coping mechanism. This also can create a huge barrier to engagement with providers because they're not going to agree with the assessments. They're not going to be forthcoming with the information, which is something that I saw in the chat, right? They're not providing the information that is going to help them and going to help the provider understand. Um, but they're going to feel a lot more skeptic about getting that support and being able to do what quote unquote they're supposed to do because it doesn't feel right. To be another example, well, to be more specific, a history of family trauma. When we're talking about survivors of domestic violence, right? They may be distrustful of providers due to their prior experiences, as I said before. They may also be fearful because of the trauma that they have experienced. And even though they are in need of services, they may not be sure that they're going to get the help that they need because sometimes they're not believed, right? Things are like so outrageous as to what's happening in their households that it's not something that they feel that it will be believed. Also, they can be very, very fearful of losing their children to the system because of what's going on in their houses. And that's a real, real feeling, right? And it's something that as a provider, I have an understanding of how important it is to be able to support that and get people out of where they are. But as a family member, you also have the feeling of, you know, does it make sense, right? Would it actually provide me the help that I need? So there's so many layers to this work. There is so much that goes on when you're working with families and creating those safe spaces and building those relationships, because families are not always going to tell you everything that goes on in their lives, right? And all of these things that I'm mentioning could be potential barriers to engaging, to partnering, to building any of those relationships. Then again, it could come from anywhere. This can definitely, it is multi-layered. So as far as cultural and religious views, this can be protective factors, right? It doesn't necessarily need to be a barrier to engagement or partnering with families, such as Indigenous Americans, right? They don't view mental health as a negative thing. And if we don't take into account how to deal with the different cultures, we would not get to understand why when they are dealing with mental health, they're not dealing with an individual. They're dealing with everybody, right? With their community. They are introducing everybody and they see themselves as a collective identity, right? So understanding nuances that come with working with different cultures and different families. It's also fun to get to know what other people do, right? And maybe what is a barrier for me or what is like very like black and white for me, it's not for everybody else. Same thing with religion, right? It can be a way that people cope with their mental illness. It doesn't necessarily have to be a barrier. And it could be perceived as a barrier for us uh, if we're not understanding how does this fit into the family that we're working with, or what is it that their beliefs or their their cultural backgrounds are, um, and we don't take the time intentionally to create those relationships with them to get to know a little bit more. Um, okay. And lastly, would be social determinants of health. So I'll go through this. Economic stability. So we understand that this domain addresses poverty, employment, food, housing, and security. For example, a single parent who's working 2 minimum wage jobs with irregular hours and lacks paid sick leave. Their child can need maybe like weekly therapy for anxiety, right? So what does this look like for them? Just being able to have those conversations and ask through our assessment for more understanding. Yes, Jennifer, I see your comment. Thank you so much for sharing that. Neighborhood and built environment focuses on housing, transportation, safety, access to healthy foods. For example, a family that lives far away and their nearest mental health clinic is 50 miles from where they live, and they rely on an old vehicle with limited reliability. Like, how do they get access to services? How can they do that when they have these barriers, right? Being understanding of those things. Social and community context, which focuses on discrimination, social support, culture, and community engagement. For example, I say a family who recently arrived to the United States, facing language barriers, social isolation, maybe has experienced stigma regarding mental health in their home country. So what does that look like for us, right? If we don't understand that those are some things. Education, access, and quality of focus on literacy, early childhood education, and vocational training, for example. We can talk about a parent who is not savvy of forms and paperwork or any medical jargon and language, but they receive complex text-heavy intake forms and psychoeducational materials. And even I'm thinking of IEP forms, right? Being part of those teams, like not understanding anything that is being said, yet being expected to support their child because this is what needs to be done. And healthcare access and quality, which addresses insurance coverage, health literacy, provider availability. And for example, we can say a young adult needs a specialist who's out of network, or the community clinic has a 9-month waiting list to serve all of their clients and or the people that they're working with, but they're severely understaffed. So what does that look like? Now that we have covered family ecology barriers, we are going to shift a little bit to what barriers look like from a systemic and organizational lens. And I'll pass it right back to Lydia.
Thanks, Maria. I think we'll go through this pretty quickly because there's a lot of overlap, I think, in some of these barriers, and we're just going to highlight some examples on the system. But actually, I think Maria also highlighted some when just talking about social determinants. So I'm also mindful, like the reality of this work is that barriers can come from all sorts of directions, and it's not just the three people in the room. Like it's not just you, the parent and the child, that are contributing to these barriers, but that there's larger system and organizational barriers at play. And Maria mentioned a bunch of those as well, just even talking about social determinants. So, for example, at the system level, right, they exist outside of like maybe the professional or the family's awareness, or out, they don't necessarily have direct control of them. They're larger systemic issues like a fragmented mental health system, services that aren't coordinated, infrastructure, the cost of care, for example, laws, policies, regulations that affect access and use of services. So there's this larger layer of barriers that does play a significant role, and those issues kind of trickle down to both you as a provider, but also the family as well. These are harder to deal with. This oftentimes involves a lot of advocacy work, and it takes a long time. But I think we want to be mindful that this isn't just up to like the couple people in the room in the session, that there's larger factors at play. We also wanted to highlight organizational barriers. And I think we are much closer to these organizational barriers, and we do actually have potentially a bit more influence here if we want to explore what these barriers are. So, for example, at the organizational level, like what are some things that are happening that may contribute to people lack of engagement in services, right? So, are there policies and procedures that exclude family voice and choice? Are there policies and procedures that seem to be more deficit based, for example? Is there organizational culture that does not support family and youth participation? So not just voice, but kind of like it inadvertently, we may be sort of pushing families away without maybe even kind of realizing, or maybe unintentionally. Is the organizational culture and language towards family and youth negative? Or do you really sort of ensure that there's like a very infusion of like person-centered and family-oriented kind of language throughout? Is organizational culture trauma-informed or culturally responsive? Like, how does that play out in policies and procedures and communications, in support of staff, in how you connect with families? So there's a lot of organizational layers here too that sort of is important to keep in mind, and that may be at play in terms of barriers. So we've done a lot of talking, and we want to give you all a chance to talk and to spend a little bit of time connecting with each other as well. And I see you guys are been fantastic in the chat, so we want to give you a chance to be in breakout rooms. We'll probably do 8-minute or so kind of breakout rooms. You'll be kind of randomly assigned. So Angelique, let me know if there's any other instructions there. Each room, we ask that each room have one note taker, because we are going to ask that person to share when we all come back together, what are some of the things that came up in their discussion. You will get a vignette sent to you in the chat box. So it's already in. If you look in the chat box, it says Training 2 Vignette. That's basically sort of a case example. We're going to ask you to read that case example together and then highlight as you're reading it, what are some potential barriers you see. If the note taker can sort of jot those down, and then when we come back together, we would love to hear from you all. What are some of the barriers that you saw? So Angelique, what's our next step for getting everybody into breakout rooms?
I think we're all set. I just wanted to confirm the length of time. You said 8 minutes?
Yeah, I think so. That gives us, there's yeah, I think 8 minutes is sufficient.
Okay, perfect.
You have time to do wrap up and after.
Okay,
8 minutes is fine.
I'm all set on my end. I can open the rooms now.
Fantastic.
All right.
Sorry, I got kicked out. Am I supposed to be in a breakout room?
Yes, I can help you with that. I'll move you
Thank
into
you.
one. Mm-hmm.
I'll share and be sort of looking close.
Do we turn off the recording while they're in?
Oh, yes, I could pause it.
Welcome back, everybody. I know it's probably a quick breakout discussion, but we hope you had an opportunity to read the vignette and highlight some of those, some of the barriers, many of the ones that we've talked about, and maybe even some that we didn't get a chance to talk about, but that you noticed. And hopefully you had a chance to talk with each other a little bit. I think what we want to do is just take a couple minutes for you to share. I know there was a note taker in each room, so I'm wondering if, for those of you, there's a lot of rooms, so we probably can't go to all the rooms. If there's somebody who wants to sort of raise their hand to unmute themselves, we can go to you. For others, I'm wondering if you can just take a minute and chat in some of the barriers that you saw or some of the things that came up in those discussions. So I think, so I see one hand. Jacqueline, do you want to share?
Well, it's not to share out. A barrier that the group had was some people wasn't even able to pull up the document, and it
Oh,
was
very
really
good.
not enough time to really answer to the questions, because by the time we went to go to the chat to get the information, we were already sent into the breakout room. So if it could be
Okay.
possible before the group start, maybe in attachments, y'all could submit the information.
Mhm. No, thank you so much for that feedback. We're sorry that some folks had difficulty accessing or downloading the document. For any group that did get a chance to talk about the barriers, I see some folks kind of chatting in. Anybody who raised their hand that was able to have that discussion? And I see Stephanie. I think Stephanie, your hand was up first. Did you want to share any barriers or any thoughts
Sure.
that came out of your discussion?
Yeah, so we had quite the list, but some of the things, I guess, to just pull out of that, somebody mentioned in the chat, and we said too, the language barrier or limited language proficiency, mental illness stigma from the parent towards the child, academic pressure, and lack of trauma-informed care and support from the school, perhaps lack of psychoeducation for the parent on the child's mental health challenges, financial economic issues, time constraints, even cultural barriers.
Mhm. Thank you so much, Stephanie.
Yeah.
And Carrie, I think I see your hand raised. Did you want to share as well?
Yes, that's fine. Can you hear me?
Yes.
Okay. We said cultural barriers. There's also a transportation barrier. There was a stigma about the Latino families that the
Mhm.
therapist had. The therapist had her own biases, language barrier again, and there was a housing issue.
Yeah.
That's
Yeah.
pretty much all we got.
No, you guys did really good. And I think in the chat, we have some folks that said that mom doesn't accept a child's diagnosis, is a primary caregiver for 3 others. So it was the 2 youth and her parent, relies on public transportation, had challenging experiences with a past provider. So there's a number of things there that sort of played a role. Split caregiver household with dad living outside of the country as well, and that's sort of the toll that that plays. So thank you so much for everyone. Cultural, socioeconomic, systemic, and so thank you that you definitely highlight some of the larger categories. Lack of informal support, the mom really sort of having to handle everything. There's a couple social determinants I think that were in there as well, and difficulty working, for example, and things like that. So thank you so much, everybody, for having, giving this a chance. I know it wasn't as long as we had hoped, but I think we all sort of got the gist, and you're welcome to continue looking at that vignette or even utilizing it in your own sort of practice, or if you want to use it maybe in staff meetings or things like that, you're welcome to utilize it as well.
And I just wanted to add, Lydia, if you don't mind,
Go ahead.
I just want to validate that it was dense. We are talking about barriers and we're not moving forward to how to fix anything or anything like that, because that is the next training. So we want to validate that this was not an easy task, and it had a lot of heavy words and a lot of challenges this family was going through. So thank you so much for doing the exercise. Thank you for going over it. I just wanted to add that.
Thank you so much, Maria. I do want to shift to actually sharing some resources, right? So we spent a lot of time talking about sort of what these barriers are. As Maria mentioned, Training 3 is going to really focus on strategies for partnership, and things you can do sort of from day one with working with families. One of the things we want to do, though, is share a couple tools and resources that you'll have available to you, that can help you kind of start the conversation with family on assessing and identifying barriers, right? So one is, like, we know that there's a lot of barriers that could be at play anytime we're working with families. Okay, so how do we start identifying those? So I'm just actually going to share a few resources that are in the slide deck. As mentioned in the chat, the webinar recording of the slides will be posted on the mcsilverta.org website in about 2 business days. So you'll have access to the tools and to the links and everything once that's posted. But let me see if I can share my screen and walk you through some of those tools. So we wanted to highlight, we have 2 tools that can sort of help you think about how you can start having those conversations with families around assessing barriers. So we have one, and again, it's maybe not fully comprehensive. It's really more of a guide, and we encourage you to kind of use this in how you see fit and how you feel it may work for you. But for example, we have this provider guide that taps into some of these attitudes, beliefs, these social norms, the cultural values, practical values. And what this is it has a set of questions under each of these kind of categories that you can sort of utilize to begin having conversations with families. So this will be made available and it'll be posted on the website when we post the slides and the recording. It's not like a checklist per se. It's not like you have to go down the whole list. But I think it is a guide that where you can sort of like look at this, figure out how you would turn that into a conversation in your own style and your own sort of way of working. But we thought it's definitely a good start to tapping into a lot of the barriers that we just talked about, and maybe even some that we didn't get to spend too much time on. So we wanted to highlight that resource. One of the things we also wanted to talk about or mention is that barriers can occur at any point in time across the time that you're seeing them. So it isn't just like a conversation at the beginning when you first meet a family. It can sort of go across time, right? And some barriers can go away and some new barriers can pop up. One of the things I think that you saw in a lot of our sort of presentation around barriers was the importance of getting feedback from the caregiver and having a better understanding of their view of the services. So we have these tools actually on our website already. We have a number of family-driven care tools, but we have this form on the caregiver perspective that you can utilize and share with your families to get some feedback on how they feel the services are going and how in alignment are they with family-driven care. So this is actually an incredibly useful tool that gives families a chance to really kind of tell us how they're thinking and feeling. I will say for folks to really feel comfortable kind of sharing how they really feel, we do have to sort of build a kind of safe space where we're really open to receiving feedback. And sometimes that takes a little bit of time for folks, as you know, maybe based on past experiences. But we do think this is a valuable tool that you can use multiple times across the time across the time that you're meeting with the family. We did want to highlight some resources for you. Some of these may need to be adapted a little bit. But for example, we spent a lot of time talking about stigma, and there is this great resource, Opening Mind Scale for Healthcare Providers. It did come from like the healthcare, not the mental health care field, but it does tap into like providers' own stigmatizing views of mental illness or mental health conditions, right? And so this is really more of a self-reflection tool that you may want to consider utilizing, just kind of walking through that just really asks you like, how do you view these things? Like what, are there any sort of potentially stigmatizing views that you may have that you maybe didn't realize you had, for example? And so I thought this was a really helpful tool. It's one of the only ones I've seen that kind of look at it from that direction. There may be others, but we thought this was actually a really helpful sort of tool for self-reflection. In line with that, obviously a lot of compassion fatigue and burnout. Many of you have probably seen this. This has been around for a while. So the Professional Quality of Life Scale is a freely available tool on the ProQoL website. And it's a self-score. It's like 30 questions, self-score, really easy to use. And it's an opportunity for you to use for yourselves to kind of figure out, are you experiencing compassion fatigue, burnout? And they also cover secondary traumatic stress. So that's another resource for your own use, for your own self-care, and for your own management. And then I also wanted to highlight, because again, it isn't just about us, it's also about the systems and organizations we function in. And so we do have a number of like resources related to a stigma initiative that we had, and they're available on the McSilver TA website. And this is something that we encourage you to share back with your leadership, with your directors. And this is a bit more of a checklist, a little bit of like a self-reflection tool for organizations around how, as an organization, how you may be perpetuating stigma. In your, for example, these are sort of the core categories. So there's like questions that like leadership and sort of members of the organization can ask about where does the organization stand in each of these spaces. So it taps into leadership and governance, whether you offer peer support services, education awareness, workforce development, promotion of self-care amongst the staff, for example, enhancing service delivery and communications. And so there's a set of questions around like, are our policies and procedures potentially stigmatizing? Like, how do we know that they are or they aren't? How are we exploring what we can do sort of differently? And there's also some like resources and tips throughout. So this is a handy resource that I encourage you to also bring back that again really taps into reducing stigma. So I'm going to share one more thing. I just have to go back to the slides. This is on the slide. It's not really a tool, but it was a set of questions that we've sometimes utilized in some of the work we've done in the past. And this is really uh, kind of self-reflection on parenting views. And I think one big thing that we talked about is like the views that the family brings, right, from their own culture and beliefs and their own families, but what views do we bring as well as providers? And in particular, what are our parenting views, right? Because a lot of what we do is related to supporting people in their parenting. So what are our parenting views? What is our view of what a quote unquote good parent is or quote unquote good family looks like? And these are some questions to sort of ask yourself. Like when you're interacting with a caregiver, are you thinking, this is what I would do in this situation? Or are you tempted to change a caregiver's mind about something that they're saying is their priority? If you're thinking, if only they would do this, and if you find that these things are coming up, that may be an indicator, say, hey, maybe I need to stop and figure out where these sort of thoughts are kind of coming from and how is that potentially tied to me and not necessarily something that is supportive of the family. So another resource, I think we're very heavy on providing sort of resources that you can adapt and use how you see fit. And you may already be doing a lot of this yourself. So I want to be mindful that if you're not, here are some resources that could help. And then next steps, Maria, I think we
Yes.
probably have a couple minutes for questions. So if there's aren't any questions, please put them in the uh,
Sure.
chat box. And Maria, I think you were just going to mention some next steps for the next training.
Yeah, so next steps, we ask you to reflect on our discussion of barriers for today. Think of how you will approach conversations on barriers with the caregivers, with the families you identified, and also with other caregivers and families that you work with. Don't forget to join us on Monday for part 3, where you will be hearing about engagement as partnering and some strategies to deal with all of this. October 6th from 12 to 1:30.
And Maria, I think, here's some closing thoughts on engagement and about how it's about motivating and empowering participants to recognize their own needs, strengths, and resources and to take an active role in making changes for themselves. I also wanted to highlight, it's here too. We have a resources page that links back to where we have all those stigma resources as well as some family-driven care resources. So we do want to make sure when you get the slide deck, you'll have the links to those resources. And we encourage you to just kind of look through them, see if there's anything that could be helpful. And there's also some stigma intervention stuff in there and self-stigma intervention that could be really helpful for work with your clients as well. Maria, do we have any questions coming in by any chance?
I don't see anything at all.
Okay. Upcoming events. These are some other ones outside of this series that we encourage you to join as part of CTAC offerings to Runaway and Homeless Youth in New York. Kids Who Aren't Okay, What They Need to Know. That's Dr. Ross Green. So For those who are interested in having hearing his work, we encourage you to participate there. And for our advocates and those who are working with advocates, we do have a upcoming webinar on career planning for YPAs. Okay.
Hope
right.
everybody has a great weekend. And thank you for joining us today.
And there is a feedback survey in the chat, so please feel free to complete that. Give us some feedback around training, and if there's anything else you want to know about this topic or any topic that we can consider for future training. Thank you so much, everyone, and have a great rest of the day.
Thank you.
Take care.